Good afternoon, and welcome to the Alliance for Home Health Quality and Innovation's Learning Collaborative webinar on discovering the VNAA Blueprint for Excellence, Best Practices for Home Health, Hospice, and Palliative Care. My name is Tracey Lee, and I'm the Executive Director of the Alliance. As you may know, the Alliance was founded in 2008 and is a 501c3 dedicated to the mission of leading and fostering research and education on the value home health care has to offer to patients and the entire healthcare system. Today's webinar is part of the Alliance's Learning Collaborative series. The Learning Collaborative webinars seek to offer information and perspective to help home health providers navigate healthcare change and reform. Our webinar today will provide an overview of VNAA's Blueprint for Excellence, which is an extensive set of resources for quality improvement in home health care and hospice. We're fortunate today to have as our guest speakers Tracey Moorhead and Margaret, or Peg Terry, from the Visiting Nurse Associations of America, VNAA. Tracey Moorhead is President and Chief Executive Officer of VNAA, and in this role she spearheads VNAA's strategic vision and growth in collaboration with the VNAA Board of Directors. She effectively directs quality improvement programs, policy formulation, and strategic advocacy activities, and represents the nonprofit home health, hospice, and health promotion community before the media, allied organizations and constituents, and federal policymakers. She's recognized as a leading healthcare advocate and has considerable experience in public policy and coalition development and outreach. Previously, she served as President and CEO of the Care Continuum Alliance, an industry organization advancing population health management interventions through health and wellness promotion, disease management, and care coordination. Prior roles of hers included Executive Director of the Alliance to Improve Medicare and Vice President of Government Relations at the Healthcare Leadership Council. Our second speaker, Peg Terry, holds a PhD in RN and serves as the VNAA's Vice President of Quality and Innovation. In this role, Peg provides resources and guidance to member agencies in their efforts to improve quality of care, adopt innovative program models, and succeed in a competitive and rapidly evolving delivery system. She oversees educational programming and the quality initiative, where we're working closely with VNAA members. Peg led the development of the VNAA Blueprint for Excellence. Previously, she worked as the VP of Clinical Affairs for MedStar Health Visiting Nurse Associations as part of a regional multi-hospital integrated delivery system. She served in that role since 2005, before which she was MedStar VNA's Vice President of Operations, Quality Improvement, and Regulatory Affairs for 7 years. Before joining the VNA, she served for 6 years as president and CEO of another nonprofit agency. She is also a published researcher and educator with experience, having taught at the Catholic University of America, where her work focused on home care clinical practice, including heart failure and wound care. We're so lucky to have both of these extremely expert speakers today, so I hope you'll join me in welcoming them. Before we get started, I just have a few housekeeping notes. First, Tracey and Peg will present for approximately 45 minutes, and will leave the last 10 to 15 minutes for Q&A. Please note that this is a webinar, and we control the slides on our end, so please don't be surprised if you are unable to flip ahead. Second, your lines will be on mute. Please do submit questions through the Fuse webinar software on your computers or other devices during the presentation. And you can send a question to the speaker by sending a question to me, Tracey Lee, and I will be the one to read the questions to the speakers. Third and finally, we will be posting the slides on the Alliance's website after this webinar, and we're also recording the webinar and will post a playback on our website as soon as it's available. That covers my housekeeping points, and so I'd like to turn this over to Tracey Moorhead without further ado.
Thank you so much, Teresa, for that incredibly gracious introduction. Peg and I are quite honored to be presenting as part of your webinar series today, so thank you very much for inviting us. In reality, for those of you who are joining us, Peg is going to do the bulk of the presentation, as it's her work that has resulted in the VNAA Blueprint for Excellence. I'm going to give a bit of background on the origins of the blueprint and what we feel is the clear and convincing need for such a quality improvement strategy for the home health and hospice industries. First, a bit of background about the Visiting Nurse Associations of America. We are a national organization representing nonprofit providers of home health, hospice, and palliative care and health promotion services. You may know that there are over 3,200 nonprofit providers in the United States in the home health segment of the industry, and another approximately 2,000 providers in the hospice segment of the industry. 51% of VNAA members provide both health and hospice services, and over 30% of VNAA members are hospital-affiliated systems, agencies affiliated with hospital systems who are nonprofit. And surprisingly, nearly 50% of VNAA members are engaged in an accountable care organization or a patient-centered medical home model. One of the reasons for the Blueprint for Excellence and our desire to dramatically expand this hospital about today are some of the challenges confronting the industry. As we look at many of the challenges confronting agencies and organizations, we boiled them down to essentially a lack of clarity. We believe there was a lack of clear framework, definition, or understanding the role and value of home health and hospice. There was a lack of clearly defined value propositions across all stakeholders, payers, providers, and policymakers, and a lack of clarity on engagement opportunities for health and hospice, new care delivery, and payment models. Finally, lack of clarity on the future of the home health benefit, how it can be utilized to better serve populations are perhaps not Medicare age or who are being supported by primary care practices. We see as an opportunity to address these challenges of clarity a number of opportunities created under the Affordable Care Act. Many of these opportunities are in delivery system reform. Initiatives such as accountable care organizations, patient-centered medical home, or health models. We also see an opportunity to engage our members in payment models, including bundled payment, capitation, and risk-based contracting. We see a number of influencing our both on the home health and the hospice side. Specifically, we see dramatically expanding Medicare population, a population with increased prevalence of chronic conditions and multiple comorbidities and complexities, including socioeconomic status. We see a declining number of primary care physicians and an increasing reliance on payment for outcomes as opposed to payment for service. We see providers who are more narrowly managing their provider networks and focusing heavily on quality goals for their provider networks. And finally, we see through the Affordable Care Act and other policy initiatives an increasing interest in medical neighborhoods that rely on community-based providers and community-based services. We believe these are all opportunities to better demonstrate the value of home health and hospice services. As we looked at those opportunities and challenges, we understood the opportunity to focus on quality initiatives. And as a result, the VNAA Blueprint for Excellence was developed by VNAA to help advance quality improvement activities across our industry. Peg is going to go into great detail on some of the components of the VNAA Blueprint, but I would like to stress that we have chosen to make the VNAA Blueprint available to all interested stakeholders, nonprofit and for-profit providers of these services, payers, providers, policymakers, researchers, and academicians all have access to the VNAA Blueprint for Excellence. We believe this is a critical opportunity for us to expand knowledge, to demonstrate value, and to increase understanding of the utilization and opportunities for home health and hospice services in delivery system reform and in payment model reforms. I very much appreciate your willingness to hear our presentation today, and with that, I will turn it over to Peg and invite her to give you an overview of the VNAA Blueprint. Thank you again, Teresa.
And thank you, Tracey. And I just wanted to ask, as I'm beginning to speak, Teresa, if you would let me know whether you can hear me or are there any problems, I'd really appreciate it.
I can hear you just fine, but we'll let you know if there are any issues, so thank you for asking.
Great. I'm really delighted to be here today to share with you the work that VNAA members, academics, leaders from the 3 accrediting bodies, and others, such as individuals from HHQI, worked on over the last year and a half to develop. These 40 members are really the people who put the work together, who developed it, who shared their expertise, and I'm very grateful for their knowledge and expertise. So I did want to share that with you. And just one other thing as we begin, I like to say that we have to get quality right. And we're in a world where quality truly is making a difference, and we're all aware of quality measures that are out there today. So we have to make sure that our quality measures are risk adjusted, adequately accounting for the patient's complicated background and socio-demographic issues. We have to, and we in home health and hospice must understand how to provide care that is based on evidence and research. And so that was our goal with the Blueprint, to have care and to have practices and to have educational programs that is based on evidence and research. So I want to start with our home health definition. And to let you know, we searched hard to find a good definition for home health care. And so actually a group came up with this definition. So I'm just going to give a little background and share this with you. On the care continuum, home health is the setting in which skilled practitioners provide services to individuals and families where they live. The care is provided to promote, maintain, and restore health. Home health professionals cultivate patient engagement, self-management, and provide nursing care, physical, occupational, or speech-language therapy, home health aid support, and social services. Home health aims to ensure patients maximize independence, minimize the effects of disability or illness, and move smoothly through the care transitions, and very importantly, remain in the home. So what I decided to do in this presentation is really give both definitions up front and then move on to talk a little bit about home health and then on to the Hospice Blueprint for Excellence. What is hospice care? This is an NQF definition. Hospice care is a service delivery system that provides palliative care for patients who have limited life expectancy and require comprehensive biomedical, psychosocial, and spiritual support as they enter the terminal stage of an illness or condition. Hospice care also supports family members coping with the complex consequences of illness, disability, and aging as death nears. Hospice care further addresses the bereavement needs of the family following the death of a patient. So what were the goals of this best practice project? It was really to position the VNAA as a learning hub and network for exchange of information about current and future practices of quality, cost-effective home health care and hospice services. It was to assist in ongoing education and training for those experienced in and those new to the field, demonstrating the value of home and community-based services and the role of nonprofit home health and hospices. To actually actively engage our membership as subject matter experts in the field, and to brand VNAA members, companies in alignment with best practices in hospice and home health. So what is a blueprint? It is a pathway to expert practices. It also supports workforce development and consistency of care delivery to achieve the triple aim: better care, better health, and lower cost. The VNAA Blueprint strengthens care transitions and end-of-life care and underscores the value of accountable, measurable, coordinated care in home health and hospice settings. So when we developed this, we made the Blueprint free and publicly available to all. And I do want to share, as we're going through this, anything we talk about today, this is really an overview. To really understand in more depth, you can go on to the VNAA Blueprint .org and really look at many of the features we're going to talk about today, many of the educational opportunities. It is a staff training resource. It's a quality improvement tool, and it links to validated tools and free or university-based training. So about the modules. Each clinical section design is to be reviewed by members. It's a training over lunch or to be used as training for clinical staff online. Each clinical area identifies recommended tools and interventions, training, measures, and references and resources. Clinical pages link to VNAA training webinars, and additional training and briefs will be added as we continue to develop this. So I do want to share with you, as you have an opportunity to look at the blueprint after the call, you'll see that there are some PowerPoints and there's some webinars. VNAA is in the process of finalizing our learning management system, and so many of the PowerPoints will become webinars and will be available to all once we get the learning management system in place. So the next slide really gives you a look at what your landing page would be when you enter the blueprint. And these colorful hexagons, and if you can see them, basically we have two that have names on it. One is the home health and one is the hospice. As you enter this particular page, you'll just click on those hexagons to decide to get you into the home health and hospice. And as you can see, we have hexagons that don't have any names on it, and that's for our future development of other best practices. So the next slide gives you really a look at the modules and the best practices in the care transitions learning modules. And this is the home health sector of the Blueprint for Excellence. So I hope you can really see that we have 4 modules, and the modules are the same for home health and hospice. They are care initiation, clinical conditions and symptom management, patient and caregiver engagement, and patient safety. And so on the side of each of these modules, you can see the best practices. And I'm just going to quickly go those. Critical interventions, first and second visits, front loading, scheduling MD visits within 7 days, pneumonia or pneumococcal vaccination, that's under care initiation. Under patient and caregiver engagement is patient self-management and self-activation. Under clinical conditions is depression screening. And under patient safety we have, that's great, we have risk assessment, medication reconciliation, falls risk assessment, and intervention, exacerbation of conditions or red flags. So the next slide gives you a look when you actually enter, and this is actually a slide from our hospice section of the blueprint. You can see you can see the landing page for an actual best practice, and this happens to be a best practice for pain assessment and management. So as you enter this, you can see that there's an overview, and the overview provides a lot of background on the particular slide, some of the statistics, some of the reasons that we thought this was important. You will click into tools and critical interventions and have some detailed information on those critical interventions and the tools that are available, training programs, references and resources, and measurement and evaluation. I just want to say something about measurement and evaluation. We tried to use measures that were OASIS measures that could easily be collected, but we do have some measures that are not and that can be individualized for each organization. So now we're back in the home health one. So as we look at the first best practice, and this is what we call our critical interventions best practice. What we have here is this particular best practice, and I must say that I don't know if anybody's on the call from Sutter, but they really influenced what we did here. They were not the only organization, but they did provide some real good background as to how they do it in their organization. So we've divided this up into assessment, interventions, and tools. And just to kind of give an overview of this, in the critical interventions, you first assess and identify high-risk patients, determine hospitalization risk, perform med rec, assess understanding of symptoms of exacerbation if patient is safe till the next visit, and assess for telemonitoring. So what are the interventions? One of the interventions here is that we believe all patients should be seen within 24 hours. And the group really talked a great deal about this because, as most people know, the Medicare rules state that you only need to be there within 48 hours. But this is a program about transitions of care. And so the members felt it was very important to really try to see patients within 24 hours of referral or discharge from a hospital or another institution. The other interventions are to look at front loading, at least front loading for the first 2 visits, use teach-back method, utilize emergency care plans, personal health record, and follow-up MD appointment within 7 to 10 days. And that's all in the interventions. And then the tools that we have listed here are the Institute for Healthcare Improvement Risk Assessment Tool, Spotlight tools and zone tools, confidence rulers, as well as the PAM, the Patient Activation Measure tool. And I just want to say something about the PAM. All of the tools that we have recommended or have made available here are free and publicly available. We did include the PAM because we thought it was an important tool, although we do state that it is a tool that you must actually pay for. Whoops. Front loading. And front loading, we saw front loading in 2 ways. Front loading really looks at whether you're going to have a second visit within 24 hours of the first, or whether you are going to assess to have front loading in the first 2 to 3 weeks of home care. And so there's an assessment that's done on patients to determine whether they're high risk. And one of the things I should say here, and I'll talk about this in a minute, is that we decided to use the IHI tool to assess for a few reasons. One, because it's relatively simple. There are basically 2 questions or issues you need to deal with. It can be done before the patient actually has a full OASIS assessment. And the concern was that if you waited for the full OASIS assessment and utilized their risk assessment tool, it may be 3 or 4 days until you decide whether you want to front load a patient's care in the second visit or in the first 2 to 3 weeks of care. So we decided to go with the IHI tool. Another assessment is once you're deciding to front load, became a really important issue, is to review staffing capabilities and barriers to front loading. Most of our members who participated in this told us that it took them a few months to kind of get the staffing in place in a staffing model that allowed them to do front loading of the first 2 visits, as well as front loading within the first 2 to 3 weeks. So the interventions are, as I said, admit within 24 hours, a visit frequency of 60% of all nursing visits in the first 2 weeks for high-risk patients, and to arrange for telemonitoring or electronic support, telephonic support or IVR for the first 30 days. I want to say that, and we'll talk a little bit about determining high risk in a few minutes and the risk assessment, so I'll leave it at that. And some of the tools we have here on the site: HHQI's personal health record, high alert medication list, IHI risk assessment, personal health record, it's a Sutter Care one, Phillips National Chronic Disease, and SMART goals. The pneumococcal vaccine. We decided to include the pneumococcal vaccine. Everybody in home care knows you have to screen to see if the patient actually needed to get the vaccine or had received it in the past, and that whether they will receive it during the time they're in home health. And so as we were looking at what would we include, we decided to include the pneumococcal vaccine because many ACOs are really looking at this as a measure. And we knew some of our members and agencies across the country, it'd be something they would have to track. So giving the pneumococcal vaccine, it's complicated. We know that what you need to do is really assess whether the patient needs it, and you need to determine whether you're going to send the patient to a physician or an outpatient department, or whether you're going to try to provide the service yourself. The important thing is to design a process to ensure that immunization is really administered. And you can see here that we recommend you use the Assess, Access, and Administered. That is a program under the HHQI BIPA immunization program that they put out. And I think it's really the best program around to give you some indication of how to manage this program internally in your organization. I just want to say that this is an area we decided to continue to do further work on, and so in September we will really enhance this aspect of the blueprint. MD appointment. We also included this. Now, assess if patient has a scheduled follow-up appointment with MD, and the tool is the personal health record. We decided to say 7 to 10 days, and I can tell you that that was also very controversial because there really is no number, no specific time frame based on the research of when you need to have a physician appointment. And many organizations were telling us, well, we're working with a particular healthcare system and they're recommending we have a physician appointment within 5 days. Ours was just a broad recommendation that an appointment should be within 7 days, and basically felt that that would really cover all kinds of patients, not just those who are high risk. So the intervention, implement process to identify responsibility for making an appointment, address need for follow-up appointment, discuss use of personal health record, use coaching as approach with patient and caregiver, and implement process for patients referred from MD and incorporate changes in the medical record. Depression. We were very fortunate to have one of the members of our group, Rose Madden Bayer from VNSNY, who really has developed a depression program, behavioral health program in home health. And so she had done a lot of research on this issue. She had gotten her doctor of nurse practice examining this issue. So we were able to take advantage of her knowledge and her success with developing a really impressive depression program at VNSNY. So we used some of the OASIS questions, which is the PHQ-2, which all home health agencies must complete. It just is a basic screening. We then went on to recommend the PHQ-9 for patients 64 years and older, and we also recommended the geriatric depression scale for those 64 years and younger, and the geriatric depression scale for those 65 years and older. We also felt that if you could, at discharge, after actually assessing the need for a depression follow-up and getting some follow-up, we felt it would be helpful if you wanted to evaluate discharge using the same depression screening tool to see if there was a change in the patient's level of depression. And the tools are there on the right, and we had a few recommendations or treatment interventions. Notify the PCP of screening scores, request medical social work, referral, mental health follow-up, medication monitoring, and obtain prescription order from PCP or specialist if appropriate. So risk assessment. I have to start by telling you there's no valid and reliable tool out there for risk assessment at this point. So with that knowledge, and we had many discussions about this, we decided to go with the, as I said before, the Institute for Healthcare Improvement risk assessment tool, which are basically 2 questions. And the 2 questions really speak to the number of hospitalizations within the last year, as well as what's the patient's knowledge of their clinical conditions, and using stoplight zone tools, and and using teach-back method as a way to determine whether the patients actually could tell you what they learned. In addition to that, we recommend using the patient the importance and confidence ruler, which really is a way to measure the patient's confidence and knowledge and ability to act if a change occurs while they're home. One of the reasons we thought this was important is because one of our members and others have shared with us that one of the most important things they do when they go in to see a home care patient is they try to make sure they're going to be safe and they're going to be okay until they come back for the next visit. So determining the patient's risk determines really your staffing patterns with these patients, and really gives you a sense of their knowledge and their ability to really identify some of the issues when they change or when they need to be seen again. So the treatment is develop process for early intervention, identification, intervention with high-risk patients within 24 hours of discharge to prevent hospitalization. And again, we recommend the IHI tool, the LACE tool, the importance and confidence ruler, as well as zone and spotlight tools. And I just want to tell you, when you look at the tools, if you go into them, you can see all of these tools, you can see how to use them. I must tell you, we probably have about 30 or 40 zone and spotlight tools that are disease specific. So it's really helpful if you want to take a look at that. So exacerbation and red flags. This is really something that was part of Eric Coleman's program, and we thought it was important to include. So it kind of gets to the issue we were just talking about, you know, patients' ability to identify when something changes. So again, what were the recommendations here? They were to really use some of the tools that are available to identify their particular risk for going back in the hospital. We have a personalized red flags. We have an emergency care plan, which really is a multi-system, multi-disease care plan that can be used, that can be left in the home for the patient. A personal health record, and using SBAR with physician communication. Patient engagement. So here we are looking at patient engagement, and I have to say that this is really very important. It's sort of the underpinnings of all we're talking about here. And again, I want to say that Sutter really was very influential with us as we were beginning to develop this. So when you're looking at patient engagement, you really have to determine whether the patient understands care, whether using the zone tools or spotlight tools, and really you need to look at patients using the importance and confidence rules, whether patient is really able to take over their own care, feels comfortable, understands the importance of it, and has confidence to act if they need to. So recommended here is patient ed materials should be at the 4th grade level. We have some of the tools that we have here are at the 4th grade level. You need to communicate with patient and family, use a teach-back method, use consistent teaching materials, coaching to develop patient-centered goals, and principles of motivational interviewing. And in preparing for this, I actually went back and listened to 3 of the webinars that we had to really instruct clinical staff, and they're on motivational interviewing, they're on use of teach-back, and they're on health literacy. So I think it's important for you, if you're interested in it, you can listen to them. They're very well done, and they give you a sense of how to use this with your staff. So on to the hospice and palliative care best practices. So this best practice actually was finalized and launched June 26th of this year. For our hospice and palliative care, we aligned it with the hospice item set. We have modules on pain, dyspnea, treatment preferences and beliefs, and bowel regime. But really it goes beyond the hospice item set. We have a module on, or a best practice on crisis management, other symptoms, critical interventions, medication reconciliation and management, and other best practices that are part of this. We have references to the CMS Hospice Conditions of Participation, and we used expert work group guided this process, identified best practices, and we're continuing to update this. I just want to say we're very fortunate in developing this particular group of best practices to have several academics who've been involved in tool development as well as reviews of some of the tools to assure us that these were really tools that met the validity and reliability criteria they should. So, as you can see here, the modules are 4, and they're the same modules as before, but really the best practices are different except for 2, and that is falls prevention and medication management and reconciliation. Although I will say, even though the names are the same, actually they're quite different, especially the medication management and reconciliation. So let's take a quick look as we go through what are these tools and what are these interventions for some of these. So we're going to start with pain. And pain is a very important measure is a very important measure, a very important symptom to screen and measure and assess. And I can say that, as everybody knows who has a hospice or working in hospice, this is one of the process measures that CMS has required: patient screening and patient comprehensive assessment. So what we did is we were able to look at tools that are out there. We're able to identify them. So we have some of the tools that are here: the visual descriptive tool, the VDS, the Iowa pain thermometer, the FACES that has been revised, the brief pain inventory tool. And for those who cannot self-report, those patients who are not verbal, we have the pain ad for adults, and we have the FLAC for children. For the FLAC is only valid and reliable for use by children. And some of the interventions with pain are clearly those that are non-pharmacological, those that have medications that are non-opiates, and then the opiate meds. As you're looking at and as you're reviewing this chapter, and this is really a very cursory overview of this particular best practice, when you're looking at medications, you need to consider dose, adjustments frequently, route, plan for breakthrough pain, use of e-kits, management of side effects, and bowel regime. All of that is critical in terms of the pain screening and assessment. And in there you'll see that we recommend, and as you look at this in more depth, you'll see that we recommend some particular pain screening tools that you will have to complete when you're completing your hospice item set. So dyspnea assessment and management. Here we have the assessment includes the presence of dyspnea, the severity, and the effectiveness of treatment. And under dyspnea, we have several scales that we recommend, or tools. They are the numeric rating scale, visual analog, the modified board, which people may know from home health, and the respiratory distress observation scale, the RDOS. I just want to say something about patients with dyspnea. Patients who enter hospice may have dyspnea at the beginning, and other patients and can self-report at the beginning. But many patients who have shortness of breath or dyspnea as they move along their illness, that they really can't self-report at the end. So the RDOS is a very important measure to use. The interventions, some of them are non-medical, non-medications. They are positioning, environmental, the environment, the FAM, breathing, evidence-based oxygen, controlled anxiety, opiates, anti-anxiety meds, bronchodilators, and corticosteroids. Newer practices are the use of nebulized Lasix and nebulized morphine. I just want to tell you the other thing that we have done in the blueprint is there are some practices out there that are really not based on evidence, and one is the use of oxygen for patients at the very end of life. It's not always recommended, it's not always effective. And so what we say there is, we don't say that this is not something you should do, we say that there's no evidence to really support this. I just wanted you to know that we've not just recommended, but we've also decided on what really there's not an evidence to support the practice. So into treatment preferences. Treatment preferences, as you all know, is a very important part of hospice. In here we discuss treatment preferences, include CPRs, life-sustaining treatments, hospitalization, and this has to be done within 5 days of admission according to the hospice CMS and the hospice item set. We use the conversation, project, and pulse, which is the physician order for life-sustaining treatments. And the interventions and treatment preferences are to coach caregivers on ways to prevent crisis hospitalization and ensure that they know how to communicate with hospice staff 24/7, and reaffirm initial preferences with patient and caregiver. So beliefs and spirituality. I just want to tell you, as we developed some of the work around beliefs and spirituality, it became really clear to us that this is a very difficult area for many people involved in hospice care. And so what we were able to do is find some really helpful tools that can be used for patients that really can help start the conversation and really open up the conversation and provide the clinician with some support as you're trying to deal with spirituality. This is not about religion, it is about spirituality. So the assessment is to discuss with patient caregiver within 5 days of admission, and this is what you need to do for the hospice items that are the CMS. The National Consensus Project suggests a structured instrument. It needs to be culturally appropriate discussions. So we have several instruments here that we recommend. One is the NEST, another is a spiritual guide to assessment tools, and the last is FICA. And I particularly like FICA is that it provides some really clear, structured way of trying to assess the patient's needs and desires around their own spirituality. Some of the interventions are to offer pastoral care, use structured approach, and incorporate it into the care plan. So others on the team will know what the patient's preferences are and spirituality interests. So distress, symptoms, and final days. It's not just about pain and dyspnea, it's also about many other symptoms. So we decided to develop a whole series of information on the rest or these additional symptoms that patients have. So I'm going to name them real quickly. The nausea and vomiting, fatigue, delirium. By the way, 70% of all patients in hospice have delirium at the end of life. Anxiety, bleeding, wounds, death rattle, diarrhea, constipation, and depression. What we have done is we've taken each of these particular symptoms and we have the way to assess. We have several suggestions for tools as well as other ways to assess. We have interventions that we suggest, and we have ways to sometimes measure how the patient is doing and how they're improving. And I think this is a particularly strong section, and I want to say also that this goes beyond what Medicare or CMS has requested. And there are many tools here to assess how patients are doing with these 10 other symptoms. And I'm going to kind of quickly get to the next three, so I can finish this on time. So critical interventions, it starts with the ability to assess. It starts at time of referral. You need to assess at referral and determine hospice readiness. And one of the members of our group used to say, is the patient ready or the patient and family ready to take the hospice pledge? So assess patient and caregiver understanding, medical conditions, complete physical assessment, symptom management, and caregiver and medrec and psychosocial, the intervention by the MSW. And the treatment is really to discuss levels of care, services available, complete election consent, rights and responsibilities forms, discuss advance directives, and confirm the decisions that the patient had on their prior advance directives. So I just want to do a few more in here. In crisis management, I thought was really an important contribution that our members of the group could make. 25% of all patients that enter hospice are there for 7 days or less, and 10% are there for 3 days or less. And as the people on a call would call it, when you enter hospice, basically, some people, it's like an ICU for some of these patients. Things happen very quickly and they change very quickly. And so what we came up with were the red flags for the need for crisis management. And I thought that was very important to share that with others and to understand what they are. Once we understand and we can start getting involved, the most important thing on these very short-term ICU patients, as we call them, was to establish a therapeutic relationship and to really be in the present for these patients. Very, very important. And to involve the interdisciplinary team, and to consider a joint social work nursing visit at the first visit, because there's a lot to be done and these patients are not with you very long. To identify patient and caregiver concerns and to get the symptoms under control. I just wanted to mention a few things on MedRec and management. This is this is sort of what we have for home health, but I wanted to say for hospice, it's a little bit different because as you begin to work with patients in hospice, one of the things you need to do is you need to sort of see, well, do they need to be on all those medications they're on before? Is it really necessary? Can you switch out something they're on and really give them something that's more appropriate for hospice? And some of the members of this group have shared with me that, or share with the group, that this is really a very difficult aspect of dealing with medication reconciliation and management. Again, having family feel comfortable with the changes and the decrease of some of these meds they've been on for a long time. And the other skill that's needed here is the skill of the clinician. Clinicians must be comfortable with first dosing, titrating, tapering, changing from one form of an opiate to another, changing the route administration, and use of dosing among different opiates, and use of PCA pumps and IVs. Falls risk, falls prevention, just want to say one thing about this. We did recommend the MAC-10. Many people said, well, hospice patients score the highest level on MAC-10. But it is a valid and reliable tool for risk assessment in home health. It has not been tried it's not been looked at for hospice patients. But it does tell you where their particular risks are and what they're due. And that's the value of using the MAC-10. And so with that said, I just want to summarize. I just want to tell you that the purpose of all this is to really maintain the viability of our industry, to really use informed best practices, to provide consistency of care, and to really use these to assure that there is consistency of care, become the standard to bring value to what you're doing into the industry, and also, as I said before, patient-centered commitment. Under the underpinnings of all this is patient-centered care. So with that, I just want to tell you where we're going next real quickly. We've launched home health, hospice, palliative care. We're developing technology best practices, patient remote monitoring, and we're beginning a clinical conditions group to include heart failure, COPD, diabetes, hips and knees. And I want to encourage everybody to use this, to share it with whoever they want. And I want to recognize our sponsors, the Joint Commission, Select Data, McKesson. With that, I'd like to turn it over to Teresa. Thank you.
Thanks so much, Peg. That was a great presentation. You covered so much ground, and I'm sure that there are those on the phone who are, maybe feeling a little bit overwhelmed by how much there is, but appreciate all of the ground that you covered, and also that website for making sure that we're able to go and look at it in more detail on our own. But at this point, I want to encourage everybody on the phone who has a question to please use the Fuse chat box to submit your questions that I can read to our presenters. And in the meantime, while we're waiting for questions, I thought I would just ask you guys a couple questions that I had after listening to your presentation. So, Peg, you mentioned remote monitoring best practices as sort of the next areas that VNAA is going to be looking at for the blueprint. So I'm wondering if you could share any thoughts or perspectives that you have on how home health providers, and I guess hospice too, are using telemonitoring today as part of their quality improvement efforts, and whether there are any unique issues that you see insofar as looking at best practices in this area as compared to what you've done already for home health and hospice and palliative care.
Well, first of all, this is in development, so I wanted to make that really clear, but patient remote monitoring is really looking at sort of a different animal, I'm going to call it. And as we began to look at this, we decided to, because there is equipment, and equipment is really part of what you need to be aware of when you're doing patient remote monitoring, how you use it, how easy it is to use, the cost of it, all those factors. It's a little bit of a different approach. So as we're beginning to look at this, we've divided it into categories: clinical, the clinical issues we're going to address, the patient and caregiver experience, the operational side as well as the financial side. So I think if the question is, it's going to be different. I think there are a lot of people out there using remote monitoring now. A lot of people have been using it for a long time, predominantly in home health for the traditional diseases, but we're seeing it a lot more for other diseases as well. It's not just the heart failures and the COPD and hypertension. It's really for, and diabetes possibly, it's really for some other illnesses and some other issues. And one of the things that that looks like we're going to be, that's been recommended from some of our members is they actually just do a risk assessment of patients, and anybody at risk they put on a monitor. So it may be a multiple of diseases, but if they're at a high risk for hospitalization, they're considered, they try to put them on remote monitoring. We have several members also that use it not just in their home health agency, but have used it as standalone service with coaching, and have had success with getting contracts within their state and their local areas to do this. So I think remote monitoring is really an important part of preventing hospital readmission. I think the rest of healthcare is interested in it. I think a lot of people in home health have been doing it for a while, and I think it's a great time to really look at, kind of take it apart a little bit and see how we can really understand it better and make some recommendations based on that.
I think that's really great, and I too sort of would echo the feedback that you had about hearing about some home health agencies even having sort of separate contracts that are not part of the Medicare home health benefit, sort of serving various patients in coordination with their hospitals and health systems in their area, or maybe with private payer contracts. So I think that's great, and certainly very much an area that's in need to be addressed. So thank you. I don't see any questions yet, but one more question that I had to do with sort of fitting the blueprint into the big picture of the healthcare system. So one of the big issues for patients and for the healthcare system is really care fragmentation and poor coordination of care, which of course leads to poor quality. So I'm wondering how you see the blueprint as aiding efforts to build bridges across the care continuum. And really this is a question for both of you guys, both Tracey and Peg, because I know that both of you know a lot about this area.
Well, I'm happy to take the first stab at the question. So the home health is really called the home health transitions of care. So this is really designed to really have a smooth transition into home health. And there's a lot of evidence that in home health, and the first few days of that transition time are really when a lot of readmissions occur, a lot of anxiety by the patients, and so really kind of providing an intensive service at the beginning is very important. So I think that's why it was designed the way it is. That's why we recommend, seeing the patients within 24 hours. I think it's from the perspective of the home care agency. We didn't really try to tackle the health system. We tried to keep it to what could we do in home health and hospice, and to really empower both in home health as well as in hospice. So I think the contribution the Blueprint can make is really to assure smooth transitions into both home health and hospice, and to really quickly, whether it's using, being aware of the practices around the crisis management, when we have short stay patients and the red flags that would really have you concerned about particular patients, being aware of what those are and making sure that those patients move in quickly and get the services they need. So I think it's really very front end, but there is a coordination aspect in terms of dealing with the physician to make sure patients have further follow-up. So there are certain areas that we were able to address it on a larger scale, not just in home health and hospice.
Thank you, Peg. And I would add, at kind of the bigger picture level, really what we were attempting to do, again, is put a framework on what partners in the form of physicians and also payers could expect in a transition health, and how we can demonstrate the quality and the consistency of home health in onboarding individuals and helping ultimately to reduce unnecessary hospitalization. I share with you that when I came to VNAA, and Megan and I were talking about the project that ultimately became the VNAA Blueprint, I had a conversation with a colleague who is a national medical director for a health plan. And this colleague's comments to me were really focused on the fact that they have high regard at this health plan for visiting nurses and other home health aides, but that they really felt that there was a lack of consistency from one agency to the next. That if there was an opportunity to greater consistency so that they knew what they were going to get when they contracted with a home health organization or when they recommended a particular home health organization as an ancillary provider to physicians in their networks, they would be more inclined to rely on home health as a value-added service as part of their network management. And so as we think about what is the value, how do we demonstrate the value to the broader healthcare delivery system, I think that's a critical insight from a national payer and one that we keep in mind every day when we are looking at opportunities to expand the blueprint.
That is exactly what I was thinking, Tracey. And as you know, we've done a little bit of work in that care transitions area as well. And I have definitely found that when I've had interactions with other provider communities outside of home health, the hospital community and whatnot, that there's really a lack of understanding sometimes about exactly what home health providers do. And the same might be true of hospice, but it might be more true of home health. And so I absolutely think that your blueprint, could go a long way towards just that, education effort as to what is it exactly that home health is and can do for patients who have multiple chronic conditions and for patients involved in post-acute care. So I absolutely think that this is a great resource in that respect too. We actually got a question that came in, and I think this is a good one to just address because it maybe was tucked into Peg's presentation, but maybe not called out specifically. The question was whether home health provides palliative care or whether you have to be a hospice provider to provide palliative care. And my understanding is that there are many home health providers that offer palliative care outside of the context of hospice. But I'd love it if Peg, you could talk a little bit about sort of the role of each type of organization in palliative care.
Great. Well, a lot of, in a way, as you look at palliative care, and we addressed it a little bit in the definition, but as you look at it, and there is no palliative care entity, as everybody knows, and so providing it in home health is really sort of the best option. And so I think some of the information from the hospice and palliative care blueprint really provides a lot of help to home health agencies as patients are moving through and receiving care, because you can begin to see the changes in the patient. You can deal with some of those medications these patients may be on, and for whatever reason they're not going to hospice yet, or they're not ready, or they maybe not, or that end stage, but it gives you a look at some of the symptomology that you need to treat. And I think we've done a really broad look at that and have a lot of information to help home health agencies in working with patients who are really end-of-life patients, but not quite in hospice yet. So I think I would suggest, I think there's a lot of applicability, especially around the medication section, around the symptoms section, around the tools that are available. It's just not, you don't have to deal with actually the CMS requirements and the hospice item set. So I think it can be used by home health agencies that are dealing with those end-of-life patients as well. And I think when I had been in home health a long time, and I'd never seen, if you're in home health, you may not be living in the hospice world per se. And I think this gives agencies or organizations an opportunity to see what some of the needs of these patients and families are and to incorporate it.
Great, thank you, Peg. This is a comment, more a comment than a question, and this comes from Jetty Edelman. She says that, thank you for the excellent webinar, and that related to home telemonitoring, that Texas Medicaid does have a new limited reimbursement benefit for home telemonitoring just since October 2013. So, just to build on, what you've already said about telemonitoring, Peg, that it's definitely sort of starting to gain steam and an excellent time for us to be identifying best practices. So thank you for that. I don't see any additional questions, and we're at 4 o'clock Eastern. So I'm going to thank both Tracey Moorhead and Peg Terry for a really tremendous presentation about the VNAA Blueprint for Excellence. I think this has been really wonderful to get an overview from you. I'm certain that a lot of our listeners will take a look at your blueprint online, and any questions. I think we've provided in the slides Peg's email address, because Peg is sort of the point person at VNAA on the blueprint. We're going to be posting those slides on the public portion of the Alliance's website immediately after this webinar, so I encourage all of you to take a look at those slides. I want to thank everybody for dialing in, and I hope each and every one of you has a wonderful afternoon. Thank you.